So we've got a pretty robust agenda today, along with breakout rooms. So I'll go through fairly quickly. We're going to take a look at who our team is made up of. So I'll be introducing our new teammates as well. We'll break a bit for a moment of light, which will be led by Alexander Zemo. We'll have an overview of Project Firstline at NCUIH and what year 2 will look like. Our guest speaker today is Elizabeth McClune from the CDC. She'll be presenting an overview of Project Firstline. Then we'll go into breakout rooms for fellows or contractors and or champions, and we'll take a deep dive into what year 2 requirements will be. So next slide, please. Welcome to our orientation to Project Firstline at NCUIH in its second year. It's great to see returning champions and new fellows and support staff, as well as their guests from the CDC, who is sponsoring the Project Firstline National Collaborative. Briefly about NCUIH, it's a national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives living in urban areas. NCUIH is the only national representative of the 41 Title V UIOs under the IHS and IHCIA. NCUIH strives to improve the health of over 70% of the American Indian and Alaska Native population that lives in urban areas, supported by quality, accessible health care centers. I do see a pop-up that folks are trying to join the room. Project Firstline is a national collaborative led by the U.S. Centers for Disease Control and Prevention to provide infection control training and education to frontline healthcare workers and public health personnel. NCUIH is proud to partner with Project Firstline as supported through the cooperative agreement. CDC is an agency within the Department of Health and Human Services. The contents of this program do not necessarily represent the policies of CDC or HHS and should not be considered an endorsement by the federal government. A brief introduction to our Project Firstline team. Most of you are familiar with our Project Firstline team from year 1. Today, Evie Mahal, Aaliyah Smith, myself will be assisting with facilitating our breakout sessions. Dr. Fowler is the Vice President of TARC, which is Technical and Research Center, Technical Assistance and Research Center. Our Director of the TA Division is Sapara Fuller. Alec is our statistician. Alyssa Smith-Longi is the newest member of the team. She has joined as our Public Health Associate. Our Communications Associate, who has recently joined the team, is Lamar Weaver. Recently joining the team as one of our facilitators is Marie Zephyr. Cal Mitchell, you've met. He was a facilitator for our initial webinar this year, and Karen Klock is returning from last year. Karen, as you're aware, is a family nurse practitioner and technical advisor. She has her master's in nursing and in public health. She's worked over 20 years in health equity with resilient communities, and she's been working with a Native American population. She provides direct patient care and service as well as manage operations workflow in infection prevention and control in various areas. She's worked in disaster relief area with post-Hurricane Maria in Puerto Rico, as well as on a CDC-led biosecurity project. Next slide, please. Cal Mitchell, who will be our lead facilitator, is a decorated Army veteran. He is a Purple Heart recipient, as well as the Bronze Star with Valor. He's a graduate of the Arizona State University with a focus in communication. As a program manager with a background in business development, and Cal, forgive me if I am not pronouncing this correctly, Kiltso Bito, which translates to bushes where the yellow flowers are. He founded this organization that provides a professional service in sharing oral traditions in hopes of breaking down stereotypes. As a trainer and facilitator, Kyle serves as the Senior Program Analyst in the House of the Vice President of Academic Affairs Office at South Mountain Community College. He uses storytelling to connect with Indigenous students and with his own Diné childhood. Within Navajo culture, at least the way that I see it and the way I've been brought up, is that we always move forward. And I'm quoting Kyle, we move forward with three things: songs, prayers, and stories. So everything we do in our culture is related to those three things. Kyle will be bringing his storytelling expertise to our webinars. So it has that feel and approach, and will be a little bit different as we roll out our webinars. Next slide, please. Marie is the owner of Red Day Women Consulting and serves as a consultant with NCUIH. She has over 15 years of tribal health quality experience. She provides quality assurance, facilitation, strategic planning, data analysis, and processes improvement expertise. She received her bachelor's from Creighton University in 2009. She has a master's in public health policy and management from the University of Arizona. She's the mother of one daughter, numerous nieces and nephews, and enjoys crafting during her free time. Next slide. It's my pleasure to introduce our fellow Zoe Harris. She's a community health science doctoral student at the University of Illinois Chicago School of Public Health. Zoe is a citizen of the Mashpee Wampanoag tribe and has worked with her own tribal community as well as Native populations in Boston and Chicago on topics of education, health promotion, and language preservation, specifically among youth populations. Zoe, like myself, is also a Jamaican citizen and has family roots in Selma, Alabama. In addition to her work on Indigenous wellness systems, she's worked on projects related to suicide prevention, social determinants of health, and racism as a public health issue. I'd like to introduce our champion sites, which are returning champion sites. Next slide, please. Bakersfield American Indian Health Project is based in California. It's an outreach and referral facility. They have a public health nurse and community health care worker outreach. They provide in-home healthcare assessments to American Indian and Alaska Native elders 60 and above that have disabilities and or are homebound, cannot access healthcare due to transportation barriers. Their services and programs ranges from transportation, case management, youth prevention program, nutrition program, pharmacy, diabetes, and behavioral health. The project directors assigned are Johnny Delgado and Joseph Anderson. Welcome. Glad to have you back. Next slide, please. From Fresno American Indian Health Project, we have Felicia Batts. They are a full ambulatory facility. Last year they've developed, implemented, trained, and evaluate infection prevention and control program with a focus on urgent COVID-19 pandemic. They seek to improve the existing patient and staff safety efforts, enhance quality improvement efforts with increased staff training, monitoring, and reporting. They've revised and revamped existing policies and procedures and implement system improvements to advance a culture of safety and develop contact tracing and case investigation efforts for persons testing positive for COVID-19. They offer a range of services as well. Welcome. Glad to have you back. Next slide. From Native American Connections, or our program directors, Jennifer Thompson, she'll be joined by Alyssa Payone as well. We'll be assisting her on the project. Native American Connections is a residential or outpatient treatment center. Development, they focus on the development and implementation of an organization-wide infection prevention and control system. The overall objective is to increase clinical and quality safety competency and establish policy and protocol infrastructure that encompasses the needs of clients and staff within the residential outpatient integrated health and housing program. Welcome back. Next slide, please. We are going to transition to a moment of light. I'm going to hand over to Alexander Samo for him to open up the floor. Alec, handing over to you.
Thank you very much, Diane. So yes, I want to take a moment now for what we call a moment of light, which is an opportunity for you to be able to share anything you would like with the group, anything that you find worthy of being shared. This moment of light can be something enlightening or illuminating or interesting or fun. We're not just working together, we're also fellows here. So please feel free to come off of mute if you would like to share, and please introduce yourself and your team. Also, if you do not feel like sharing, it's quite all right. So please.
Hello, everyone. I just wanted to introduce myself. My name is Marie Zephyr. I'm a member of the Oglala Lakota Nation. I was born and raised in Pine Ridge, but currently reside in Rapid City. And I'm really excited about the work that's being conducted on this team. You have some good stuff going on. And I just wanted to introduce myself and say I look forward to working with you all.
I'll go next, Alex. I just want to say that it's remarkable to have folks returning to a second year. I'm very happy to see familiar faces as we move forward with the activities for this year. It's been wonderful working with this team, and I know that this year we'll be able to do great things. Thank you so much.
Hi, everyone. I'll go ahead and share a thought. Welcome back, our 3 champion sites, our contractors and our SMEs, and Liz from CDC, and our core team here at NCUIH. Year 2, there's a lot of work up ahead, but I congratulate you all, and I commend your efforts to be with us today and moving forward. There's a lot to be done for and with our healthcare workers, our warriors on the front line. And through this project, we learned last year that many of our sites had tremendous amounts of challenges, but we were able to come together and brainstorm and bring ideas to the table to really improve the way we operate as a healthcare system. And so I'm very excited. We do have some experts in the room that have done some healthcare system change work, but with this project is through the avenue of IPC. So that's exciting, and I just wanted to just welcome you all again. And thank you for joining us.
Hello, good morning, everybody. My name is Kyle Mitchell, and I just want to say I'm very grateful for this opportunity to be part of NCUIH and look forward to year 2 and developing relationships. So I have my contact information. Please feel free to reach out. And again, excited and looking forward to the future. Thank you.
So, thank you so much for all who wish to share. I would like to return it back to Diane.
Alec, briefly, Project Firstline had certain key foundational and practical knowledge directed to more than 6 million frontline healthcare personnel and targeted components of the public health workforce to protect the nation from infectious disease threats such as COVID-19. This was the major goal for Project Firstline. Within this were certain key concepts that built out the program, such as core training, practical tools, partner engagement, mentorship, public health, technical capacity building, and innovation. Under these umbrellas, we were able to develop a number of initiatives to build our program, and you will see these throughout the various products that we produce and co-produce with our partners. Next slide, please. So just to recap, for our year one Project Firstline, it was under a cooperative agreement, OT 18-1802. This focused on strengthening public health systems and services through national partnerships to improve and protect the nation's health. As we transition from year one, we'll look at emerging and re-emerging diseases. And under a year two cooperative agreement, under a different grant, the focus is now on improving clinical and public health outcomes through national partnerships to prevent and control emerging and re-emerging infectious disease threats. Next slide, please. What does this mean for year one? There were 11 activities that were rolled into our program strategies. Most activities are completed. Remaining activities has rolled over into a carry forward, and our champions are working on completing their videos, evaluating training platforms, and implementing the training gained from year one. Next slide, please. In year two, the program strategies will be a little bit different. The project topic areas focus widely on environmental health, health systems transformation, infectious disease, leadership development, minority health, surveillance system infrastructure, workforce development, and others. Or program strategies will fall into 3 areas: disseminate and adopt training, inform and adapt, target and train. Next slide, please. The program strategies are defined as disseminate and adopt, to support CDC in dissemination and adoption or implementation of guidance, clinical guidelines, and best practices for the prevention and control of emerging and re-emerging infectious diseases. Under inform and adapt, we seek to inform and support CDC in the development and adaptation of guidance, tools, and the best practices, including collecting and communicating individual expert opinions that can inform updates to existing guidance that consider the needs of specific patient populations, clinical specialties, and industry sectors. Under target and train, we'll engage frontline personnel and lead training in CDC best practices for the broader workforce, supporting the prevention and control of emerging and re-emerging infectious diseases. Will target guidance and tools to better reach communities or populations at increased risk for infectious diseases, and reduce disease spread in targeted workplaces or settings. Next slide. Under the first strategy, inform and adapt, we have conducted a retrospective review, which has been folded into what we call virtual dialogues. These are essentially listening sessions where we talk directly to urban Indian organizations to understand the status, needs, and how UIOs may integrate the training topics with focus areas in clinical guidelines and best practices. We will host a panel discussion during the annual conference to share the lessons learned through Project Firstline, share our activities related to the implementation and steps UIOs have taken to incorporate the trainings provided with Project Firstline. Next slide, please. Under target and train, we'll be producing 3 virtual webinars to target or 41 urban Indian organizations. We'll also be creating and developing ECHO community of sessions, at least 6 of these. We'll have up to 3 podcasts to reinforce key messages from our webinars and or echoes, 3 to 4 podcasts or 3 to 4 virtual webinars. Next slide, please. Under disseminate and adopt, NCUIH will enhance this existing IPC UIO champion program. We have new and returning CDC IPCU champions. They will participate in live trainings, ECHO, as well as podcast development. We will host 2 fellows to support the champions in their program, and we'll create a communication and engagement plan. Next slide, please. What does the program outcomes look like? Short term, we're looking at increased distribution of existing infection prevention and control guidance. Existing guidance is adapted to increase adoption. New guidance is informed by target frontline prevention and control personnel. Into intermediate outcomes, We're looking at increased number of healthcare professionals who are trained and understand best practices for infection prevention and control, increased adoption of IPC guidance, expanded participation and reach of living learning networks. Next slide, please. I'd like to welcome Elizabeth McClune, Liz McClune as we call her. She is the program lead for Project Firstline. She works in the Division of Healthcare Quality Promotion at the National Center for Emerging Zoonotic and Infectious Disease within the CTC. Welcome, Liz. I hand over to you.
Thank you, and thank you all so much for being here and for being newly interested or continuing to be interested. It always strikes me before we even get started that this isn't your only day job, and so you're volunteering to take on more activity and more work, and it shows just your commitment to healthcare, to patients, to each other. And is something that so often gets overlooked, but shouldn't. So if nothing else, take a moment to really give yourself a pat on the back for stepping forward, not once for some of you, but twice. And really your dedication to providing safe care. It's no small thing, and it doesn't go unnoticed by anyone on this call, to be sure. So my goal here today is just to provide you kind of an overall orientation to the National Project Firstline group, knowing that every partner that we work with is unique and brings something truly special to the collaborative. And so learning about how NCUIH has implemented Project Firstline is always such, hearing it every time is exciting. So we'll start with the next slide. So one is just kind of a review of why we're here and how we came to be. So unfortunately, with so many things, COVID-19 really highlighted some gaps in knowledge and practice in healthcare settings. This is absolutely not an indictment of the healthcare community at all. The gaps actually reflect that there were these disparities in infection control expertise in the workforce due to differing levels of infection control training that folks received. There's different gaps in what you receive on the job. So some may receive a quick checklist, some may have received an in-service. My training is as a medical social worker. So I think my infection control training was get a flu shot during my orientation. And someone said, yep, Liz knows infection control. And I guarantee you before I started this job, that was not true. There's also just been a lack of investment in understanding what works best for training healthcare workers. These are adult learners, as you know, and so our classroom-based approaches the best, our on-the-job approaches, and what does that mean? How do you integrate it into a group that is almost by definition not tied to a computer all the time, but is up and moving and interacting with patients and whose day-to-day is really unpredictable. And then finally, there's been a historic framing of infection control, and CDC has been a part of this, to be sure. Infection control is a combination of rules and policies and procedures, of audits, of demerits, really framing infection control as kind of like a hall monitor approach to a part of your day as a part of an integral part of how you provide patient care. Their actions, their behaviors, their choices that you make that are all supposed to move towards helping people heal and go home and be with their families. And that includes you as a healthcare worker. And so by framing it away from the human side of motivation, it's often so easy for knowledge to not translate into practice. Next slide, please. So at Project Firstline, we look at infection control differently. It's not that there aren't regulations involved. We respect and love our OSHA colleagues, for example. But at its heart, infection control are actions that you take. They're the things you do that are either supported or not supported by the systems that are in there around you. So a perfect example is, we can say do hand hygiene, but if there's no hand sanitizer around you, then the system has not supported you in taking that action. It's the culture of shared responsibility that's developed. So I have had the honor of being in a lot of different healthcare systems, and their culture around infection control has been varied. Some, it was your responsibility if you saw someone not using hand hygiene to remind them whether they were a doctor, whether they were a nurse, whether a social worker like myself. And for some, it was kind of like, what's the worst that could happen? So that's that culture around how important these actions are to keeping each other and our patients safe. But the bottom line is that the goal is that we want to keep people from getting infected and getting sick, which when you boil it down is something I don't know if anyone's anti that. I almost want to meet them, but we don't want our patients to get sick or sicker. We don't want our healthcare workers to get sick or to potentially expose their family members. So for us, next slide, please. When Project Firstline looks at this, there's an education and training component to all of those levels. It's not the golden bullet. It's not solving everything, right? If there isn't PPE, the rest of this isn't helpful. But if we can train on a individual action level, a system level, and how you develop a patient safety culture, we really think we can move the needle on keeping people from being sick. Next slide, please. So that all led to the founding of Project Firstline in October of 2020. Our goal is to all work together. We are at heart a collaborative to increase knowledge and understanding of our frontline healthcare workers. I think the original estimates were 6 million. I think the probably better ones, if you're defining anyone in a healthcare facility, is about 20 to 23 million. It's a lot of people of varied roles, of varied backgrounds, and that includes, of course, patients and family members and residents of long-term care. But we're committed to providing effective infection control resources to all of those folks that are grounded not just in our science of transmission spread, but adult learning, educational best practice, but mostly, and you heard it from Diane, what do people need? What are their preferences? How do they want to receive information? How can they receive information? And our goal is to get to know healthcare workers intimately and diversely, and to celebrate that, and for us to do the adaptation and bring the knowledge and education to them. They're busy enough. They shouldn't have to go searching for the knowledge. Next slide, please. So I'm not going to go through this amazing list that kind of seems like the invite list to a wedding I would love to go to, but we are a collaborative of a lot of partners. I think last count was 75 partners, and that kind of grows by the minute. We have our clinical partners that range from long-term care, from our nurses, peds, dialysis, to those that represent the different diversity within the healthcare system. So obviously our NCUIH colleagues, but also our Asian Pacific Islander American Health Forum and our National Hispanic Medical Association, that's really helping to make sure that when our content is adapted, it's adapted in a way that's to be best received by the full diversity and breadth of American healthcare workers. We also have a strong public health component. So next slide, please. Public health is clinical health, and clinical health is public health. I think COVID has really taught us that there really isn't a real dichotomy between the two. And so we have our public health partners that help to operate as trainers and to better understand the healthcare worker needs in their jurisdictions rather. And then finally, next slide, we have our academic partners who are helping us to better understand what works. How do healthcare workers think about infection control, and what does that mean for training? How are things really spreading in healthcare, and what does that mean for training? How can we harness technology like augmented reality and have that be a tool to use people who may live in rural or critical access areas? Next slide, please. So we've continued to spend time listening to our healthcare workers. We're not done. This is not an end goal for us. And I'm not going to go over all of the things here because it's kind of preaching to the choir, but at its heart, healthcare workers are people. They want to feel valued when they're being trained. They want a recognition that they're busy and exhausted. But they also want what they're learning to be connected to why they get up every morning, even in the middle of a pandemic when it could be risky, which is patient care. They want people to get better, and they want to be recognized as a being that has existing strength, which often training doesn't. It's coming from a kind of knowledge deficit, and now we've given you the knowledge as opposed to let's scaffold off of your strengths. And they want to know why. And I think that's a fair thing. I have a 3, almost 4-year-old, and I don't get through the day without 17 whys. And I don't think that phase ever ends. You want to know why you're being asked to do something. And if you know that why, and you know that why is about protecting someone, you're much more likely to do it because it has meaning to you. Next slide, please. So I want you to feel free to explore our website, cdc.gov/Project Firstline. So we're not going to show the whole video or anything like that. I know time is tight, but when we're developing our new curriculum, which we released last week, and really welcome you to explore it, and we welcome your feedback, we wanted to take all of that input and feedback and help people move away from a more rules-based dogmatic approach to infection control, do this, and this. And to go back to recognizing infection risks in healthcare for themselves, like you recognize a fall risk, a medication error risk, to really build and scaffold off of those strengths. And how we do it here at Project Firstline is reservoirs of germs. If you know where germs are likely to live and how they're spread, you're more likely to know how to intervene at those points. So we have a bevy of new material. Next slide, please. From overview videos to a brand new website that's actually been retooled to become a teaching tool that has lots of interactive activities, but also provides information just directly. Next slide. We have training toolkits. So if you go to work in the morning and someone says, hey, you need to do an in-service and you don't know where to go, you can come to our website. We have scripts, interactive, discussion-based activities, PowerPoints that really help walk you through how to train healthcare workers to recognize risk and take action. Next slide, please. We also have some do-it-yourself gamified interactive activities. We're about to add more in the coming week or so that really takes identifying risk, the need to know the why, and just the tasks that people do. There are an order to tasks. And gamifies it, always explaining the why. I love fidgeting Felix. He's my favorite. A patient who, you're trying to start an IV and you think you're ready to start that IV and you turn over and he's scratching at his arm. And those are just the human element of patient care. And what do you do to make sure that that isn't a risk? So again, invite folks to use these materials in their trainings, but also to encourage people to do it on their own. Next slide. And then we have a suite of infographics that help to explain this concept by reservoir. So there are germs always on your skin. It's a good thing. You do not want sterile skin if you can help it. There are germs in our respiratory system, our gut, our blood. There are germs in the healthcare environment. Even the best cleaned healthcare facility has germs in these places. The world is not sterile. We don't expect it to be. But that means that there's inherent risk in what we do. And so helping to connect where germs live to risk, task, and the actions we take to reduce risk is really important. So you'll see these for the body and then for the environment, which is on the next slide. So you'll see devices, even things like a pulse ox can be a great source for things like neurovirus and C. diff. Water and wet surfaces, tap water has germs in it. And it's safe to drink, but can get you into trouble if you're immunocompromised, and dry surfaces as well. Next slide. And then I'm just going to pause for a second because this is my celebration because you guys are a part of these numbers. This is just the first year. And when I say we kind of kicked off and built the plane as it was on the runway and we were supposed to take off, I'm looking at Diane and she was like, I remember and wish I didn't. But even as we did that in the middle of a pandemic, with changing guidance, with changing virus, we all together accomplished so much and reached so many people. And the feedback was so positive that they felt like it was worth their time. And Lord knows time was very, very valuable to them. So if we can do this in 1 year with all of the headwind that we had launching, I'm so excited to see what we all can do as we move into future years together. So I think that's my last slide. Alex, I'm so sorry if I'm wrong. Yes, okay, so just come and join us on social media and on the web. And again, thank you for being here. I'm so excited that you are and grateful as well. Back to you, Diane.
Thank you so much, Liz. We are very much excited to go into year 2. So we have a number of breakout rooms here. I'll be running the Champions breakout room to go over the requirements. Aaliyah Smith will work with Zoe Harris through fellowship program, and Evie Maho will work with our trainers or facilitators in the contractors breakout room. So bear with us as Lamar gets us into the breakout rooms. If it doesn't automatically assign us, then we'll have to do it manually. So Lamar, we hand over to you to get us into the rooms.